2021 is, we thought when we left 2020 behind that things were going to get a whole lot better. And obviously 2021 has kind of said, hold on, I still got a little bit more for you. And so we've gotten through this winter storm here in Texas and in the Houston area. I hope everybody did well with that. I know that we still have a lot of folks that are recovering from that, and our thoughts and prayers are with them as they continue in their recovery. At this point, I'd like to introduce Sean Kurian, our administrative fellow, and he's our chapter board observer who's going to give this morning's reflection. I'll turn it over to Sean.
Thank you, Noel. Today I'll be talking about the reflection, but first I wanted to show a visual on what this reflection is going to be about. So just think about this as I speak over the reflection now. So this is from an unknown source, and it's called the black dot. One day, a professor entered his classroom and asked his students to prepare for a surprise test. They all waited anxiously at their desks for the exam to begin. The professor handed out the exams with the text facing down, as usual. Once he handed them all out, he asked the students to turn over the papers, and to everyone's surprise, there were no questions, just a black dot in the center of the paper. The professor, seeing the expression on everyone's faces, told them the following: I want you to write about what you see there. The students, confused, got started on the inexplicable task. At the end of the class, the professor took all the exams and started reading each one of them out loud in front of all the students. All of them, with no exception, defined the black dot, trying to explain its position in the center of the paper. After all had been read, with the classroom silent, the professor started to explain. I'm not going to grade you on this. I just want you to give something to think about. No one wrote about the white part of the paper. Everyone focused on the black dot. And the same thing happens in our lives. However, we insist on only focusing on the black dot. The health issues that bother us, the lack of money, the complicated relationship with the family members, or even the disappointment with a friend, all troubles at work. The dark spots are very small when we compare everything we have in our lives, but they are the ones that pollute our minds and most of what we think about, actually. So take your eyes away from the black dots in your lives. Enjoy each one of your blessings, each moment that life gives you. Be happy and live a life filled with love. Thank you. I think you're muted, Noel.
I am. Thanks, Sean. I forgot about that one piece you got to do there. I really appreciate your words this morning. It does give us a perspective in that we really do need to focus outside of that black dot and all the great things we have going on in our lives. So again, thank you for that. If this is your first time to visit with us, welcome. We hope that you'll join us for some more of our amazing events in 2021. And the board and Mark and the incredible work we do to as a chapter. We're doing this to serve our members, and because we want to make sure that we can continue to provide you those great educational opportunities. This morning, we'd like to welcome those who have become new members of ACHE since the last quarterly session on December 10th of 2020. Thank you for your decision to become a member of a premier professional organization and association that is close to 50,000 members across our country. We are very thankful for the support of so many dedicated partners, because we know we couldn't do these events without them. Our chapter member corporate healthcare system partners include CHI St. Luke's Health, HCA Houston Healthcare, Houston Methodist, MD Anderson Cancer Center, Memorial Hermann Health System, and Texas Children's Hospital. Special thanks to the following strategic partners whose contributions at various levels have made it possible for the chapter to provide outstanding programs to its membership and scholarships to health administration graduate students. Our Diamond Plus sponsors are Medistar and the Intercontinental Houston Medical Center in-kind contribution. Our Platinum sponsors are Page, Meyer, Harris Health, J. Tyler Services, Kindred Healthcare, Texas A&M School of Public Health, the Center of Executive Education, EEPB. EEPB are our new accountants, and this is an in-kind partner. Our silver sponsors, which is Brazosport College, Candio Partners, UT Health, School of Public Health. Please join me in thanking the strategic partners for all they do to support our chapter. Give them a big thank you. Many of our programs would not be possible without their support. In 2020, we provided over 4,392 education hours and 639 networking hours. These numbers are really outstanding, given all of the challenges that we went through in 2020. Thank you, sponsors, for supporting this amazing work and for your continued support. Our thanks to our chapter board. I'll start off with our past president, Jack Buckley, who's at Texas A&M University. Our vice president, Sandra Murdoch, who's with Texas Women's University. Our treasurer, who's Cliff J. Bottoms. And our secretary and assistant treasurer is Lee Revere with the UT School of Public Health. Our board members include Dr. Carla Braxton with Houston Methodist West, Lindsay Harper Crane with the Michael E. DeBakey VA Medical Center, Greg Harrelson with the Memorial Hermann Health System at the Texas Medical Center, Bill Hislop, Raymond Curry with the University of Houston, Raymond Corey, I'm sorry, correction on that, with the University of Houston Clear Lake, Dan Newman with Houston Methodist Clear Lake, Chris O'Keezy with the Harris Health System, Monica Rasmus with the Texas Southern University, Yvette Shaw with Texas Children's Hospital, Dave Wagner with HCA Houston Healthcare Pearland, and Elizabeth Youngblood, who's with CHI St. Luke's Health. Our fellow board observer, who you met earlier, is Sean Kurian with the University of Texas MD Anderson Cancer Center. I'd also like to thank our Educational Foundation Board. Our president is Todd Oliva. Our secretary treasurer is Mark Phelps, and our board members consist of Gina Bamberg, Ann Claire France, Ed Tucker, and Don Wagner. Thank you to our chapter committee leaders and all of the committee volunteers. We now have formed over 10 committees, and we currently have over 100 members that are serving on these committees. And I will tell you, we heard from each of these committees last week during our board meeting, and they're doing incredible work. We've made a lot of progress in this area, and we're just really, really happy to see the direction and that we're going forward with all their hard work. Our chapter awards is chaired by Laura Comer. Our community service is chaired by Guy Kao and Richie Chaudhry. Our diversity and inclusion committee is chaired by Marlene Angelos. Education and events is co-chaired by Ann Claire France and Natali Paul. Our marketing communications is co-chaired by Laura Gomez and Raj Desai. Our member advancement is co-chaired by Kevin Long and Patrick Browning. Our member and retention is chaired by Grant Magnus and Janie Ochoa. Mentorship is chaired by Panette Frebet and Maria Mikatakina. Our network and relations is chaired by Guy Kao and Maria Mikatakina, which it looks like she's chairing too. So great job by Maria. And our student member and involvement is co-chaired by Faiza Hasib and Harold Griffin. Let's give these folks a big round of applause because they're doing incredible work. If you're interested in being a part of one of these committees, you can contact Mark, and he'll be more than happy to get you in communication with one of our chairs for one of the committees as to which one you'd like to be a part of. But again, thank you all to all those who are serving. Our 2021 Student Congress scholarships have been awarded, and I'd like to recognize those individuals right now. Each year, the chapter awards scholarships for healthcare administration students to attend ACHE Congress, our national conference. So, obviously it's a little different this year. It's virtually. The rate is much lower than if you attend in person in Chicago. And so this year we're able to give a few more out. So I do want to recognize those winners right now. So our first winner is Jennifer Ho with the University of Houston Clear Lake. She's the winner of the Todd A. Kaliva FACHE scholarship. We have Kristen Amal Abraham with Texas A&M University. We have Jessica Sue with Texas A&M University, Lilac Lee with the University of Houston Clear Lake, Priya Peter with Texas Women's University, and Huda Saeed with the University of Houston Clear Lake. Let's give them a round of applause for their great work that they've done in putting in their applications. So I know they're looking forward to attending that virtual Congress this year. Congratulations to our chapter members who advanced to fellow in 2021. So this is a big area of focus for our chapter, and we've had a lot of success this year. We've got a lot of individuals who have taken the course, and obviously it's paying off. But we've got 6 members here who advanced so far this year, so we're really proud of them. I'll start off with Mayar Mohajer, MD, Cody Hunter, Maria Mikanakina. So Maria's gotten quite the attention this morning. So great job, Maria. Congratulations to you. Marie Trace, Enrique Valdez Jr., and Allison Wells, MD. I do want to highlight, we got 2 physicians that had advanced out of the 6. So that's quite a, obviously we've been trying to get a lot more physicians involved in ACHE as physician executives, and they're obviously seeing the importance of attaining the fellow status. So congratulations to our 2 physicians, as well as our other 4 members. I'd like to share some news from National. So one of the big things that everybody's always asking questions about is recertification because of everything that's been going on with the pandemic. So if you're due to recertify at the fellow at the end of this year, it's been extended, or last year, it's been.
You are muted.
Somebody muted me. Where did I miss off, Mark? Mark, you're muted.
I think you said something about last year, like if you were certified last year.
Recertification.
Oh, yeah, so let me start. Somehow or another, I got muted. I didn't touch a thing, so we have a gremlin in the system. I do want to share the news from National. So I know that many of you are that need to recertify. There's from last year, you've got till March 30th of this year to get your recertification in. I know I'm one of those, and I got all my paperwork in, and I did everything online, so it's real easy. So if you need to certify, make sure you do that before the end of the month. Our ACHE full membership link requirements to become a fellow was reduced from 3 years to 1 year. So again, great opportunity there. Those of you that are looking to advance, this is an opportunity to, with that reduction from 3 years to 1. And as I shared earlier, ACHE Congress 21 will be fully virtual this year, and it runs from March 22nd through the 25th. Early registration ends today, so they did extend that because it was they had set a date in February, but they extended that through today. So if you want to participate in the virtual Congress, please do that by the end of the day so you can get that reduced rate. You can do that by going to www.ache.org. So at this point, I'd like to transition over to our breakfast event this morning, and I'd like to introduce our panel moderator, who's Mark Mundey. Mark has been a consultant at Meyer, a leader in executive compensation consulting for 15 years, and has 25 years of experience in compensation overall, having previously worked in human resources environment. Mark's clients include public and private, for-profit and nonprofit organizations, and he's worked extensively with clients in the healthcare industry. I'd also like to note that Meyer is a platinum sponsor for ACHE, our chapter, and I'd like to thank them again for their support. So Mark, the floor is yours.
Morning, everybody. I'd like to introduce the panel. First of all, the topic today is the state of COVID in Southeast Texas. So it's a hot topic in everybody's minds right now, as it has been since this all started last year. First of all, Dr. Khalid Almoosa, Chief Medical Officer at Hermann, Memorial Hermann, Cypress, and Katy hospitals. Dr. Deborah Sukin, Regional Senior Vice President, Houston Methodist, Chief Executive Officer, Houston Methodist Woodlands Hospital. Dr. Mohajer, Associate Professor and Medical Director of Infection Prevention and Antimicrobial Stewardship for CommonSpirit Health Texas Division. Dr. Bela Patel, Vice Dean of Healthcare Quality and the Division Director for Critical Care Medicine at the McGovern Medical School at the University of Texas Health Science Center in Houston. She's also the Vice President and Regional Chief Medical Officer for Memorial Hermann Hospital, Texas Medical Center, and she holds the Graham Distinguished University Chair. And finally, Toni Vonwenckstern. She is the VP and Chief Nursing Officer at Memorial Hermann Texas Medical Center. And the first subject we're going to touch on here is one that obviously has gotten a lot of attention recently, and a lot of it is because of the recent developments in this area, which is vaccines. First question being, and I'm going to dispense, I hope this is okay, I'm going to dispense with the titles just to simplify things, but I'm going to start with Khalid on current availability. Where are the vaccines right now, and how we're talking about Southeast Texas, so what is the availability of the vaccines been to this point?
Good morning, Mark. Good morning, everyone. Thanks for having me. So I'll just share, what I know on that. Obviously, as everyone knows, the availability continues to increase. At least I can speak from our system, Memorial Hermann Health System, like other health systems. We're getting more and more as time progresses, as the availability is increasing from anywhere from the manufacturers to the government to the state to the operations and the process for doing that. As we're getting that as well, we're able to distribute it through different aspects of our system, parts of our system, outpatient, inpatients, where we're able to slowly, again, give and provide it to an increasingly broader scope of the population. So I think like everywhere else in the country, it's getting better with time. We're also learning and improving our process of distributing it, of actually providing the vaccines and putting it in patients' arms. That whole process from registration to providing the vaccine, I think that's all improving as well. So I think overall, it's getting better. It will probably get better. We're very similar to other parts of the country in that respect. So I think overall there's progress, but there's still a long way to go in terms of that.
And I'll throw it out to the rest of the panel. Has there been any different experiences out there in terms of that availability, or maybe the timing of what's coming? Or does that mean everyone's in agreement essentially? I think Dr. Almoosa did a pretty good job of describing where we are right now.
I think everybody, this is Toni, I think everybody's in agreement. I think one of the things that we started with was it started in the hospitals, and we're finding some of the other methods that are being used of late where people could drive through and get vaccines has been much better received, and you could use different staff versus the staff that you also had in the hospital. So I think we're getting better at it, and when we get larger amounts, we're finding better ways to give it faster.
So let's talk about the differences between the top two vaccines from Pfizer and Moderna, and then Johnson & Johnson obviously just brought something online. So Al, if you want to handle this one.
Sorry, who's you referring the question to?
Yeah, to you.
Okay. Sorry. It's,
Sorry. I think maybe, go ahead.
I wasn't sure. So, I mean, the vaccines, different types. So we have three major types: Pfizer, Moderna, and more recently approved Johnson & Johnson. Pfizer is approved age 16 or higher, while the other two is approved age 18 or higher. So that makes one difference. Pfizer needs to be given 21 days or later, while with Moderna it's 28 days or later, and Johnson & Johnson it's only one dose. So that's also something to pay attention to. It's really important to say that, I mean, one of the challenges is Johnson & Johnson has a little bit less effectiveness in terms of mild and moderate disease. So it's close into 70 percentile, 78% versus the Pfizer and Moderna are around 95%. However, what's really good that all vaccines are effective in terms of prevention of severe disease, with Pfizer and Moderna around like 100% and Johnson & Johnson around 90%. So it's good. It's any option that you have will prevent patients from getting admitted to the hospital and improve mortality. So there's obviously an ethical question in terms of who should get Johnson & Johnson. And what I've seen, obviously, one key consideration is to have Johnson & Johnson for the areas that they, for example, need fridge requirement temperature below the regular fridge temperature, which is required by Pfizer and Moderna. So that will be one way to use Johnson & Johnson. The other way is to have Johnson & Johnson for a population that they don't want to come back for another visit. So those are currently the 3 vaccines that are approved here in the US.
So just as a follow-on, you mentioned ages in terms of how one of the vaccines would be used, and also in what cases you would consider the Johnson & Johnson. Are there any other reasons to use one vaccine versus another, depending on the type of population or individual? Is there...
No, I mean, there are no other reasons like to choose between these vaccines. There is no like different contraindications between them. So, but the only thing really to mention is like, for example, if someone got Pfizer the first dose, they're not interchangeable. So they have to get Pfizer for the second dose. I know in other countries, I've seen in England that they did say you could do interchangeability, but most countries in the world have did not recommend that because we don't know if that works. But in terms of like I have, for example, asthma, should I go and get Pfizer or Moderna? There is really no data to show one would be better in certain populations over the others.
And that was one of the other questions, was actual preferences from one over the other, but it sounds like this is really more of a circumstance of best availability and in your own particular circumstance or region that you may be in or something like that, I would assume. Okay. Okay, let's talk about implementation. So we have the vaccines. How is the implementation across the community? So we're talking again about Southeast Texas. Are there challenges reaching that 70% goal? And Bela, maybe you can handle this.
Sure. Clearly, there are challenges reaching that 70% goal. I think right now, as the volumes are increasing of the number of vaccinations we're getting per week, at least the numbers of individuals who want to get the vaccine, we're actually penetrating that component. We do worry about the underserved communities as far as healthcare reach is concerned about whether they're getting adequate access. So we are trying to go out of our way to make sure that zip codes that have increased numbers of COVID cases, we're trying to reach those communities as quickly as possible. And then, of course, the concern that individuals have about the vaccine. So there is a significant portion of our community that is still concerned about getting vaccinated. And I think that's going to be really important to keep on open communication, making sure that we're communicating the safety of the vaccines, the fact that there's a really high likelihood of preventing hospitalizations, nearing 95 to 100%. So it's really a great vaccine, even though it's newer technology. There's been very few side effects, if any. And then I think we need to communicate that to make sure that we continue to not only reach the 70%, but even get further.
A question did come up. I'm going to throw this to the panel if somebody can answer it. Is there any time frame when the vaccine will be available to the 18 and younger individual?
That's a really good question. And that's going to really depending on where we're doing in terms of vaccination rate. I know the state of Alaska has just recently, like I believe yesterday or the day before, said they're gonna open the vaccinations to everyone in the country. The rate of vaccination of their population right now, when I checked yesterday, is around 27%. So 27% of the people there received at least one dose of the vaccine. So they are the only state who have done so. In Texas yesterday, I've seen that starting, I believe next week, we will open the vaccinations up to anyone who are the age of 55 and older. So that's so we're gonna see a little bit more relaxing of the rules. But when it will be open to age 18 or 16 or older, that's gonna depend on how long it would take us to improve our vaccination rate. Sadly, we are right now maybe number 46 in the country in terms of vaccination rate. So we have good room for improvement to get to where like Alaska is, let's say, for an example.
I would just add, I think actually for Pfizer, it's 16 and older. And so actually I know Texas Children's for their populations, which are vulnerable, whether they have comorbidities, whether it's neurological, immunosuppressed, et cetera. I know that they are actively working on, again, 16 and older that might meet that criteria. So that is happening. And of course, there are trials that have started in our community for those who are actually younger than 16 in the research phase. So those things are happening parallel to this conversation.
Another question about the vaccines in general. Are there other vaccines that are expected to hit the US market? Somebody mentioned Novavax in particular. Anything soon? Go ahead,
it's in process.
Okay.
There are I think three additional vaccines that are thought to probably hit the market in the next 3 months. So just depending on obviously FDA approval and the usual processes, but by the summer we should have about an option of 6 vaccines. And so I think that'll really help not only accelerate the vaccination and getting to 70, but then back to that question of pediatrics. I think as soon as the adult population is vaccinated, I think that you'll be moving to healthier children, especially when the studies should be done by then. I think there's 3 pediatric trials going on currently for healthy children. And so at least we'll have those results and start moving down to a younger population.
And how is Texas doing in general as far as getting people vaccinated right now relative to the national average, let's say?
Fortunately, it's we have room for improvement, let's say. I mean, we are, when I checked yesterday, we were at number 47 in the country. So the states around it. So we're only ahead of Alabama, Georgia, Tennessee, and Utah, or actually we're just slightly maybe behind Utah. So now we're number 46. We were hit a little bit after the storm. The storm definitely put us a little bit behind, but we were already in the 40s before the storm. But after the storm, we end up back to a number like 49. So we did make some improvement after the storm, for sure, but we still have room for improvement to go. I mean, most states are in their 20s and some states are in high 20 percentile. So I think it's, we could work a little bit to get a vaccination rate a little bit higher.
Yeah, I think the total numbers from last that I got from Austin was that 2.4 million Texans have had the first dose and, have had both doses. And so double that have had their first dose. So at 4.5 million, we still, we have to hit a 15 million, 16 million adult population. So still moving faster as we're moving forward, but really still have lots of opportunity.
I think one of the things that has been difficult for everybody is there was no guarantee on what the allotment you were going to receive. So it's very hard to plan how many vaccines you're going to give appointments and get it planned out a month ahead when your allotment was coming on a weekly basis and the different places didn't know how many they were going to get. So I think that is getting more consistent and we will gain a lot of ground.
Getting a lot of questions, so I'm trying to sift through them before we move to the next one. I don't want to use up all our time, but there's a lot of interest right now. How about hesitant? Toni, let me go back to you on this one. How about hesitancy on the vaccines themselves? The population, there are people who are not convinced about getting vaccinated? How do we address that?
That's a difficult one, and it's going to be education, education, education. One of the things we found is women of childbearing age have particularly been nervous. We've also had some socioeconomic groups that we've seen even within our own hospital that have been very hesitant. There's different things we're trying to do. One is put our OBGYN physicians, who are also on national committees that support the vaccination, help them do the education to the population that it affects. So there's a trust level. We've also felt like a lot of things we've done is through email, right? We send an email or we send a text and you sign up to get an appointment. And if people are not as savvy, it can be the elderly population or language barriers. We're trying to offer different ways for them to be able to sign up to get vaccines. I think when you get in some of the more rural areas, we'll still continue to have that hesitancy. Some of it's a language barrier and some of it is education.
Mark, I'll also mention, this is not so much a scientific problem as it is just a human behavior and human nature problem. So I think in addition to the educational component, there's that concept of, for example, social proof, right? Everyone else doing it, people I know and trust and respect are doing it. So I think from the very beginning, we got doctors to do it, we got senior leaders to do it, we saw some of our political leaders do it. I think we extend that to the community, such as our community leaders, our religious leaders, institution leaders, schools and things like that. That's another way that I think as healthcare organizations, healthcare leaders, we're responsible for doing that as well. So social media is another big one. Amongst our own groups, I mean, I have family members and friends who are still want to wait a little bit. But the more I share with them that, look, I got it 2 months ago and I don't have an extra nose or eye growing and I'm fine, then I think that all kind of lends more proof to it. I think that'll grow like a lot of things, as the concept of what do they call it, the diffusion of innovation. It's that slow group first starts out, and then once you get to that early majority, you get the tipping point, and then mostly everyone will start to accept it. So again, it just takes a little bit of time, but I think we're on the right track.
Yeah, and we did have people very educated that very strongly felt like they wanted to do Johnson & Johnson because it was the older, right, science. And they very strongly felt that. They'll be first in line when Johnson & Johnson starts, but they were not comfortable with the RNA.
This is a really important point, that time on this has really proven to actually be to our benefit. I mean, I can tell you whole departments that would basically say, we're not going to get it. And today, 2 months later, they're all vaccinated. I can tell you individuals in the community that would say, I'm not going to do it. And today, they're the first ones signing up. So I think that this is where people were nervous. I think the fact that we've been able to communicate that not side effects, but truly the adverse outcomes are so minute. You haven't heard about those in the news. That has definitely, I think, helped build confidence in addition to education. And you're hearing that from all of us. But I think time is just fascinating to me. Time really has been an important element here in addition to all the things that we've talked about. And I think the adoption rate we are beginning to see, once now we have supply, I think that you're going to see that definitely have an impact.
And another question came up, and this is probably for the whole group, but the hesitancy of the staff itself to vaccinate, is that becoming an ongoing issue?
I would say it's an ongoing issue, but less. I mean, I can speak certainly to our Houston Methodist organization. Again, I can clearly share with you that early on we had definite focused departments where you could identify where there was hesitancy, and I know all of us have already shared. That's where we really went in and tried to educate, bring in our chief medical officers, bring in our scientific experts to answer lots of questions. I think peers and kind of watching, this is where you see it have an impact. And the more information we could push out regarding side effects, any adverse events. And I think what's really important here is our senior leadership, our scientific advisors and physicians have come out and said clearly, week after week, when offered a vaccine, any of them, J&J, Moderna, Pfizer, if offered, take it. Because the reality is that it is 100% effective over severe illness or hospitalization and death. And as the information has come out with regard to those of childbearing age, initially they didn't have it. And then they, the ACOG, their national organization, then it's about disseminating that information. So I think it's, some of this, as we like to say, is we're living real-time science. That's hard, can be messy. But it is about continuing the dialogue and reaching those populations that need it. And we're seeing that impacted, without a doubt, even in our own workforce.
I agree. And the more we have it available for who anybody wants it, then the more who get it, and all of those outcomes continue to grow at a faster rate.
One important question here from the group is there going to be a focus on education for people of color? And this goes to the history of medicine and the community and how that has been handled in the past. Is there a particular focus right now on that?
I think there is focus on education, but it goes back to what Khalid was saying, is that, of course, education is the easy button, but the real movement will come from having trusted members in your community, in your churches, in your schools, in your neighborhoods, really diffuse that comfort with moving forward with the vaccination, and really more comfortable with, especially new technology, new vaccines, and really healthcare in general. So I think that's why we've been focusing on trying to get community leaders vaccinated in public to kind of continue those conversations. And I think it's ongoing. Clearly, probably need to do more faster, but I think there are focused efforts that are starting to show its effectiveness.
One last question before we move to the next subject. It appears that the municipalities on the rural areas or smaller surrounding areas have had extra vaccine, or at least available vaccine. I know people have been going out to those areas to get vaccinated, driving an hour or more in some cases. Is there a mechanism to reallocate those vaccines to the areas of more need, or has that been addressed yet?
I mean, I can just speak to from the state perspective. The governor is looking at, from the respective counties, the allocation. And so after analysis, and it really does look like this, we'll get a phone call on a Sunday. We're told Memorial Hermann might get a phone call, St. Luke's, Baylor may get a phone call. And when they look at specific counties, they say this county, Fort Bend County or Montgomery County, is going to get such and such allocation. And here's how it's going to be distributed. And the rest might go to a CVS or to et cetera. But they are looking at from a county allocation. I think from that point, when you talk about the actual distribution and the processes, and that's really, I think, what Toni was speaking to, which is, okay, great, you get it. How do you disseminate it out? What are all, there's not one process. Each organization has gone about approaching it in order to meet the needs of the county in different ways, quite frankly. And so, how someone can pick up the phone and live in another zip code and basically drive to, they can live in Montgomery County, but maybe get the vaccine in Galveston County. That happens, but part of that is a process that is not governed by the state. And that's reality. And I think all of us on the phone would say on any of our organizations, look, we want to vaccinate everyone. We want to vaccinate everyone in the state of Texas. We do. And so we're going about it in, using, I think, processes that we put in place to make sense. But I know all of us are working, when you ask the question about vulnerable populations, populations of color, different socioeconomics, working with FQHCs, working with, those different faith-based organizations. Again, doing it in different ways. It's not all the same, but I know all of us are approaching it with the same philosophy and concept that we want to vaccinate everyone.
It's almost like we have pop-up shops. If somebody says, Toni, you're getting 9,000 vaccines tomorrow. I mean, it is mass meetings as fast as you can do it. Go, how many places can I get it up and how can I communicate? And without knowing how much you're getting from week to week, it is like putting up a pop-up shop. And so we'll get better at it. I think the more we know and can guarantee if we ask for something, we're going to get that amount.
Mark, just an example of how the vaccine's distribution and availability is reaching these difficult populations. Yesterday, I was told by Christ Clinic, which is a charity clinic in the West Houston, Katy area, they're getting an allocation of about 1,000 doses of vaccine today, which that serves a population that is underserved, that is uninsured, a significant portion of the population of color as well. So I think the availability of this is helping reach some of those vulnerable populations as well. It's just an example of it. And yes, that includes the rural areas and the other folks that don't have access to internet or things like that. So again, there's a silver lining here. There's progress. A lot of it has to do with availability, but it's good news for everyone.
So vaccines are going out now. People are getting shots in the arm. What's the long-term strategy? What does an annual vaccination potentially look like if that is something being discussed? And is it something that's mandated?
That's a really good question. I mean, I think one is going to depend on how successful we are in eliminating the disease. So if we reach a point of herd immunity and 70 to 80% of the population reached it, and then the disease died, then that is a possibility that you wouldn't need it. That's obviously the preferred option, but it's very likely that the disease will persist as an endemic situation in pockets around the country and also around the world too. The issue is going to persist because of, it's going to take between a year or two for the rest of the world to get vaccinated. So it is very possible, let's say, that you will need like a booster, and that's going to depend on how persistent it is and also depending on the variants that are going to go in the community. So it is possible that in 6 months later, say, okay, this is the booster for the next 6 months or for the next year. The questions about should the questions be mandatory? I think that's an ethical question. I think you have to balance the public health benefits of requiring the vaccine, which is a lot of benefits, and you have to balance the risks of getting the vaccine, which has, I think, very few risks. But also when I mentioned the vaccine is not approved by the FDA, it is authorized for emergency use, which is a little bit different. So some people might say it's not even approved by the FDA. It has not got through the same rigorous process to say it's 100% safe. So I think this decision has to be debated and then determined, are the benefits outweigh the risk of making it mandatory?
So assuming that the suppression of the virus is taking place and its effectiveness is traveling throughout the world, is there a point which this vaccine moves to a primary care output? To where there's not going to be additional staffing or resources needed to deal with it on a pandemic basis? I assume that day would come eventually.
Yeah, I would say that that's really the ultimate goal, is to get it out of these urgent mass vaccination programs and put it back to where it really needs to be. And especially with Pfizer can now be put in freezers and not require the sub-zero freezers. So as these new vaccines come out and they just need to be refrigerated, I think that is going to be a huge benefit, especially to all these primary care practices that won't have the other type of sub-freezer availability. So I think that would be the ultimate goal once we get to a steady state.
Say it's too early to tell.
Yeah.
I mean, when we get new variants, or if we have a booster, how it gets disseminated once again. There was no plan to begin with. I think some of us in the hospital industry thought that there was going to be a public health response, whether it was the National Guard or whether it was something through the cities and the counties. I don't know that we all understood or were prepared to essentially become the public health arm of our respective communities, which we are, and we are all stepping up. So I think it's too early to tell, but it's something that is very much weighing heavy for those of us on the administrative front as well as on the clinical front as to how long will this go on? Do we essentially need to create new departments and hire basically additional resources because this is a new way of life? And so I think that that's jury's out yet.
So let's talk about variants. I know this is something that Houston infamously made the news on, but how is this impacting hospitalizations? And is this something that the vaccines out there are going to cover now? And then what are the trends and how it's being spread?
It's a really good question. And I think it's variants is a topic that really changes every day. So, I mean, here you have, we have in the US several variants. We have the UK variant, South African variant, Brazilian variant, among others. And we have right now a New York variant and the California variants. The measures really ones that really concerning is one is the UK, which is associated with increased spread and increased mortality. Actually, a recent study I saw that it estimates around like 60% or so increased mortality on average, which goes between 30 to 100% increase. So that is certainly concerning. The good thing is it doesn't seem it's affected by, it doesn't affect the vaccination response as much. The South African, on the other hand, is the one that might not cause increased morbidity, but it is associated with reduction of the antibody level. The vaccines are still likely to neutralize it, but the level might be less. So how much if reduced immunity that means clinically, it's still not clear, but that's certainly concerning. The bad news here in Houston that all of these variants are all detected and that we were the first city in the US that we have all of these variants. And then a couple of days ago, I saw a study that looked at the water wastage here in Houston, and they are detected in most areas of water. Like out of 39, we have like 34 areas that they have these variants. So the number are increasing. They haven't reached the point that they're affected like the hospitalization yet. But I mean, I think it is possible. These variants increase in a logarithmic, not in a linear fashion. And like I remember seeing it, the UK variant in England in 1 week, it went up from like 15% of the variants in the community to up to over 50% the variants in the community. So once they reach that critical number, they could be very concerning. So I think it's by the end of March or April, we could see that they could become a certain problem. And I'm definitely concerned about these variants, particularly the UK one.
Yeah, and there is data out of UTMB that the UK variant has been increasing week after week in their population that they've been studying. So that is concerning, especially because it's more transmissible, but also because of the mortality, as just mentioned. And we're heading into spring break. So all of those things are really concerning as we're moving forward to make sure that we're not heading into the third surge in Houston.
Isn't it terrible now that we look forward to holidays and we go, oh no, what's going to happen 2 weeks later?
There are a lot of questions. I'm going to have to move on. I think we've got a lot of subjects. I didn't work. Well, I'm going to try to circle back if we get through some of these other subjects, see if we can't answer a few more before we're done. Let's talk about the masking orders. We've all seen, unfortunately, been either exposed to people who have been anti-maskers or who have, expressed their opinion to businesses or otherwise. And now there is an order by the governor to lift those mandates. And now I just hear that the Attorney General is picking a fight with Austin. So we've got a lot of things going on right now. How have hospitals in particular responded to these orders? And are there policies or concerns from the teams and the community served?
Mark, I'll just say from our Memorial Hermann Health System, I mean, we're pursuing the science. I think like in line with with many of the other healthcare systems as well. The science here is you still need a mask. We're still putting out the fire. It's not over yet. We still need that with other infectious precautionary measures of social distancing and all that. We're enforcing that in our system the same way we've done during the pandemic. You know, wear a mask, employees have to wear a mask, visitors have to wear a mask, patients have to wear a mask where applicable, and not wearing a mask or refusing to wear a mask if you're coming into the facility is the same as refusing to be treated in the facility. So we are, as a private institution, we're able to do that, and we will do that. And our system CEO, Dr. Callender, came out very strongly with that, in line with a vast majority of our organization. We will still stick with the science and proceed until the science tells us we're able to remove that. So that's our approach.
And at Houston Methodist, we would concur. Dr. Mark Bim has been very clear. This is where the Texas Medical Center leadership of all of our organizations have come out, I think, very collaboratively. That is one thing that COVID definitely has done, I think, shined a light on. We can work together on really important public health causes and become aligned. And we are absolutely consistent. So the same goes with regard to visitor policies, masking policies, and social distancing, and all the things that we know work. The one thing all of us would, can show with data, I mean, flu is non-existent. Infection rates in all of our hospitals are probably lower than they've been in 20 years with regard to typical, as I said, typical infectious disease. So we know they work.
So with that in mind, and I know this is an area you don't have any control over, but what is a response to consumers who don't want to follow those masking policy? And then what does this look like long-term as, we deal with COVID, and then just things that we deal with on a regular basis, like seasonal influenza? This has become more of a thing that we see more frequently, like you would see perhaps in the Far East.
It's interesting that COVID killed the flu, and that, there's a rare, usually in the winter, especially, all of our hospitals are packed with all sorts of viral diseases, pediatrics and adults. Right now we've had maybe one case on our campus with the flu, and that was even questionable. So we now know that we can actually control the flu. So moving forward, when we're having, flu surges and so forth, I think we've learned that masking and social distancing we can control the flu pandemic moving forward too, anytime. And this won't be the last viral pandemic we have. There'll be future pandemics. So we have learned a lot, and and the basics work.
I think masking of people that are coming into our institution at first was harder, but like Dr. Almoosa said, and Deborah's right, we all work together. There is no option. It's written into our policies. It is the staff, it is printed so they can have it in case they need to be backed. Our patient relations department does it. In the beginning, we had staff who would walk all the way up to the door and then put their mask on, right? And patients and employees. So all the executives and our physician leaders, we all stood out at the doors at shift change and said, let's put them on, put them on. And so I think the partnership with everybody to say we were going to get this done has been miraculous. And now we know we can do it again.
So within our own organizations, and then, the mixed messages that are being put out there right now, what can we do about those mixed messages? I know we talked about there's certain things that we control, we can't control. There's education. Are there any other methods being used right now? Are there any other approaches being taken that are successful?
Well, I don't know.
Go ahead.
Go ahead, Bela.
I think if the population knew that right now there's data about natural immunity. So what percentage of Texans have actually developed natural immunity? And it looks like it's about 20%. And so then when you look at the total number of patients who've been vaccinated and the gap that still exists, I think that, that is part of the communication that needs to happen, is that we're going to get there, but we're not there yet. So, keep on doing what we've been doing, and we can get there faster. And so I know that sounds like communication, but I think it's giving individuals understanding of why we're not there yet, and just, showing the light at the end of the tunnel, but not giving up yet.
I agree. I think just doing what we're doing and enforcing it, I think a lot of the population who don't want to adhere to this will eventually recognize that you go into a certain institution, they enforce it. Okay. If you don't want to wear a mask, well, you're not going to be allowed in there. There, you're going to wear a mask. If you want to go somewhere else now that are maybe more flexible and allow you not to wear a mask, that's fine. They'll do that. I think eventually they'll all recognize as a community that some folks are just not going to change that. And eventually that'll be respected by the majority. There'll always be those difficult minorities. You know, yesterday I went to a restaurant, I got my haircut. Both places enforce the mask. That has nothing to do with healthcare institutions. So I think a lot of outside of healthcare are still enforcing that. And I asked them, you know, how are you doing? I said, we do it just the same way we've always done it before. We ask people to leave. First of all, we ask people to mask. If they don't, then you can't give them, you provide the service and you ask them to leave and you try to do that professionally. I think if we stick with that, again, and letting people know this is not going to be forever and ever, it's still for a little bit longer, I think we'll be successful in that approach.
So some of the conflicting messaging early in the pandemic were related to PPE and the need to preserve some of the masking. Is that I'm certain we've learned lessons from that. Are there any comments about that? And then with that in mind, masks in general, any predictions on how long we think this is going to last?
In terms of keeping the PPE requirement?
Yeah, I mean, just in general, I think that as long as like Khalid said about, you know, individual businesses are still practicing this because they feel a need to obviously, you know, protect their employees, protect the public. But, you know, obviously mandates are starting to fall in some states. You know, like I said earlier, and this is a different subject, but earlier in the pandemic, there were some mixed messaging. I know people keep going back to those as examples of how, you know, they were misled, but in reality, we know the reasons why early on, didn't have all the answers. We knew that the PPE was not, we didn't have the right stockpiles of it. Have there been lessons learned from that? And then, you know, the secondary question is how much longer do we think this will last?
Yeah, I mean, I think there were definitely lots of lessons learned in terms of the PPE, and it's a developing thing. I mean, and I think we should know that, I mean, we should be humble with science. I mean, there would be no way we would have known, like at the beginning of the pandemic, what is the best PPE to wear. And what also, as you mentioned, confound the issues is we didn't have the best PPE available. So we have to do with the best what we have. I mean, that being said, we've learned a lot. We've learned that one mask is really important. We learned that fitted mask is important. We learned about the role of airborne in prevention. So there was lots of lessons we learned, and things keep changing, and we still kind of keep adjusting our policies based on new studies. We learned the role when to stop isolation, and if you're going to go by duration or you're going to go by testing. So there's different things that affected our isolation and PPE use. In terms of when are we going to stop using PPE, I think that's a really good question. I saw like Dr. Fauci talking about it a month ago, and he was kind of suggesting that probably we should be using it till 2022. So I think obviously the key thing is we cannot start till we reach herd immunity, till we reach that point that a great number of the community is vaccinated. So the quicker we get to that threshold, probably we will be in a better place to stop wearing it. But then after we wear it, we will, after we get to that herd immunity, we'll have to see, are there any benefits of keeping it? And if we stopped, will we be in a problem? But I think at least till we reach the 70 to 80% of herd immunity, I don't think we should drop our guard down.
And what about the PPE inventory, the problems that we had early on? Are those things that we feel like we have a better hold on as a healthcare community?
I think we're in a far different position. Yeah, we're in a far different position than we were back a year ago.
Right.
And I would say that across the board.
And then going back to the I'm sorry, go ahead.
No, I was just going to say we haven't heard that being an issue for a long time, including things like testing as well, and testing capability and all that. even some of the treatments where earlier in the pandemic we had those problems. But you know, going back also to the point on how long to wear masks and how long to wear PPEs, and it's not the availability that's the issue. I doubt we're going to stop in the near future. We certainly may reduce it significantly because as most people agree, COVID is not going to go away. It's going to be with us for a foreseeable future at a significantly lower rate, hopefully. But those may be situations where you still need PPEs. Some people may still want to mask and socially distance even after all this is over for a variety of other reasons. So I think we'll see those habits pervasive in our community and our population for a while, for a long time, again, at a significantly lower rate.
And going back to the masks themselves, are your organizations going by the double masking protocols now? Or is that already
moved well, technically we don't go what we call a double masking. Double masking, I think that is the name for it. The CDC recommendation was really was about fitted mask, and fitted mask can come in different way. You can be sure that your mask is not leaking. The CDC mentioned that the ear loop, for example, was one of the masks that had high rates of loose fit. So that you could wear a ear loop, but you could do the knotted and tucked way. So you have to maneuver your mask a little bit. You could wear a tied mask. You can have a cloth mask on top of the ear loop. You can have a fitter. And then you could wear like other options like an N95 or KN95. So at Bela St. Luke's, we have moved to a KN95 or a cloth mask on top of the mask. But I know it's really is not only about double, it's just like what you can do to make your mask fit.
And that is what we're following at the hospitals. They can wear a cloth mask, but they have to have the surgical mask, and a lot of education on how to fit the surgical mask. Education when you wear the N95 or the K95, it's exactly following the CDC. And I think I'll have to send that education out as it comes.
Okay, so let's talk about COVID recovery. A lot of people who have contracted and then have been gone through the recovery process. I know some long haulers myself, and so I know there are a lot of issues around this. What changes have you seen in the practice of medicine and operations during the pandemic, especially in regard to the peaks and valleys of the patient volume?
Mark, I'll start. I mean, the changes are huge, ranging from how do we, license and credentials practitioners and all that, to how do we manage hospitals that are overflowing, with patients and volumes, to even the after effects of that. I mean, there's so many changes there. I mean, the obvious ones in the practice is telemedicine or telehealth. Obviously, this is not only created an opportunity to utilize technology, which is, it's interesting. It's one of those things that have been dragging its feet for many, many years until this pandemic kind of forced us to do it. But now with consultants available, not only within the hospital, but out through other hospitals as well, using some of that has significantly changed how we practice medicine, where you don't necessarily see the patient in front of you, but you're using technology to do that. I think that's a big factor. What we learned a lot in the hospitals is how do you deal with a hospital. For example, one of my hospitals was a 200-bed hospital. Well, we've had our census has hit 260 and 265. How do you manage that as well? And all sorts of very innovative ideas, beyond just the opening up certain units, if you can, the double bedding, double rooming patients in certain rooms as well, becoming a lot more efficient on who really needs to be admitted, who can be observed, who can be discharged, who follow-up is important. Getting our practitioners who usually don't manage inpatients to help with that as well. Reducing the need for consultants or the consultations being much more, let's say, brief or different. It's changed a lot. It's certainly made us, I think, a lot more efficient. I think a lot of those practices will continue on. We're beginning the conversations now with our clinicians and our hospital leaders on what does the new model look like going forward after this pandemic? How can we take what we've learned in terms of efficiencies and all that, and how can we apply that to a better practice model in the future, particularly now that it's forced us to connect in ways that we haven't really connected before beyond our own institution.
I would say we did the second surge way better than we did the first surge because we had some practice. But what we really tried to do is we opened up a new tower, as you all know, literally a month to 2 months before the surge. So we actually ended up having some empty beds because of some movement that had happened. So our job was to keep up with what were the next beds we were allowing and could we keep up with staffing. And so we could offload people. And we did it much better the second time. I think we were way more nimble and ready to make the next decisions. The one thing I think we all learned, let the staff solve the decisions because we didn't have the answers this time. So we tend to go, oh, I got that answer. I did this 10 years ago. Instead, we let them figure it out. And it was actually, they were way better at it than us. And every time we did it, they got stronger. And our job is going to be to not go backwards and to let that continue to move forward.
Well, all these pressures must have some financial impact. Elective surgeries, staffing, and just the general volume that you're getting. What has that looked like?
So I'll just jump in. I think it's looked different again all along the way. I think we all learned from what we would consider the first surge when essentially we were closed, where we stopped everything. And that was back in May. And what's crazy about it is what we hit as a peak for all of us back in May last year. When we come down off of each one of these peaks, we're not even at that level. We're still above that total number. But what I would say is we learned from that. And we all looked at each other and said, so why are we canceling our outpatient? Why are we canceling outpatient surgery? Why are we canceling our, some of us doing some of our diagnostic procedures? If this is potentially the new way of life, how are we going to operationalize? You can't just shut everything down. And then this realization that when we keep opening back up, our ERs, and you just heard that, our ERs are flooded with strokes, with hearts, with really sick, acute medical patients, and they're overflowing. So how do we then address not just a pent-up demand, how do we care for our populations? So I think that was probably this big aha moment back in May, June, to say, how do we not just care for COVID, but we care for all disease? And so with that, we very quickly had to figure out how to recover from those first, I would say 60, 90 days where we literally shut down. Most of our hospitals, were 75% less in terms of admissions, to how we were going to recover throughout that summer. And I think what we proved is all of us figured out, hadn't you just heard that, how to double up, how to figure out how to create beds in places that we had never or hadn't opened up in a long time, how to utilize our staff differently, how to utilize different technologies like virtual health, all of those things. And I will share with you that I think each one of us in that third quarter really worked hard to make up what we lost in the first quarter, somewhat second quarter. And a great majority of what I think most of us were able to do and not recover 100%. I don't think last year anyone could say we recovered 100%. But what we did do was try to meet the needs 150% of what the community demand was on us from a medical perspective, every single one of us. Third quarter, a fourth quarter, and I call what we're going through right now the fifth quarter of 2020. It's just out of control. We all thought it was going to be this new world in 2021, and it's not. In fact, it's harder because not only are caring for COVID and the numbers have come down, not dramatically, but the numbers are coming down, but our ERs are all flooded. You can go anywhere across the city. We're all holding in the emergency departments, and they're sick patients, COVID plus heart, strokes, and everything else. So I would say that going through this pandemic is no different than what Houston and all of us have done. It's important to be a strong financial organization. It's important because you can't carry out, right? We always say you can't carry out your mission, if you don't have a margin, this is more important than ever, the stability of that. And you've got to get really creative as to how you're going to continue to deliver the care in order to continue the business aspect of it, to be able to deliver that care. And I think all of us have had to look at ways to retool the deck and to continue what we all have a mission to do, and that is to deliver care for the needs.
So all the changes that are going on, all the right turns you're having to make, are some of these going to become part of a new normal in certain areas, maybe telehealth? Have you built some new efficiencies, even in credentialing? Are there some of that going on now or considering for the future?
Absolutely. I mean, from my end, I mean, what this has forced us, credentialing, take an example of that. I mean, we're able to provide disaster privileges to people within the system quickly, immediately as needed. It's helped us out. And guess what? The sky didn't fall on our heads. It worked fine. So why can't we take some of that capability and kind of, project it and use it for the future with some fine tuning as needed. But it certainly made that a lot easier to be able to trust. And I think it's helped us just connect with the rest of our system and trust the other processes in the system, maybe standardize some of those. So yes, that has helped significantly and will likely continue indefinitely. Looking at something like licensing, even beyond the system, state level. I understand there's, the Texas Medical Board has also made, during the pandemic, has adjusted some of the licensure requirements and all that, made it easier, more flexible to adjust some of those as well, even including things like telemedicine and how that's done. That's happening at a state level and probably even a national level as well. Some of those processes that help with licensure are being looked at, redesigned, remodeled to make it easier, I guess, for people to do things. So yes, there's a lot of that in our system. Also, just connecting not only with each other, but things like post-acute care as well. That has forced us trying to get people out of the hospitals to be able to make beds and accommodate those coming in, to look at the post-acute, everything from home health to post-acute facilities, the transfers. Some of our post-acute facilities also they've re-looked at their criteria for how patients are being transferred, accepted, or admitted. So I think a lot of that will continue because, again, we did it, it worked, it helped, no major issues, and we'll likely continue to do that.
On the conversely, are there things that you're doing now that you don't anticipate continuing as the pandemic wanes? Too early?
That's a good question, Mark. Life after the pandemic just hasn't sunk in yet.
Yeah.
So it may be too early, but I think it's a good question. It's a good question that we should all continue to think about. Certainly I don't like to call them shortcuts, but certainly some of the things that we've tried to minimize to just survive the pandemic may not go on. One example, we tried to encourage some of the physicians just so that, even with nursing staff, but certainly the physicians, because of the volume of patients they have to see, we said, look, we'll be a little lax in our documentation requirements. Clearly, you have to document what needs to be documented, but the full thing and holding you accountable for getting an H&P within 24 hours or whatever. Right now, it's about taking care of the patients. And when you have a flood of patients, where we want our docs and nurses and clinicians to be is taking care of them rather than in front of a computer. Those are modifications we had to make. I suspect as we come out of this, some of those things will be reversed. But it may also force us to relook at our documentation practices, if you like. So there's a lot of good things that will come out of this, but we're still coming out of this. So the answer is still to be had.
I think don't have the answers, but long-term, our nursing model has changed over this. Nurses have left for a lot of money, for a lot of good, they all had their own reasons, and it was hard to turn that away. But it is an eye-opening experience when we're sitting on that end. And so we've got to look at not just retention, how quickly we can train nurses, because they've been leaving the market for other reasons even before this. And so I do think you will see changes. I think it's going to take a while, but if we don't all sit down and look at that, we're going to be in this position again.
There's another question that came in about the viability of virtual medicine. I think that question went out to everybody. But is this a way to increase the patient access and reduce readmissions? And are there organizations that are working to leverage that?
100%. I mean, virtual all the way across. We have not only pushed out, I think, our primary care virtual visits across the board. I mean, just to give you a sense, when COVID hit, we went from doing 200 a day to 2,000 a day. Just to give, I mean, just think about that across, and that has only accelerated throughout the last year. But we're doing, our virtual ICU has gone, I will say, expanded and become more robust during this time. Our stroke telehealth platform, again, has become more important than ever, and not only for our 7 surrounding hospitals, but obviously the potential for those that we work with. As you talk about consults, virtual consults, because we had to rethink about how you interact and in some ways limit some interaction with our COVID patients. We've learned different specialties can provide their expertise using the telehealth platform. So whether we're talking about, again, doing teleophthalmology or all sorts of different aspects. So I think virtual will be a positive outcome. Sky's the limit. And it is not only important for those who are certainly here in Harris County, Montgomery, and Fort Bend County, but think of all of those in rural healthcare, the impact that it certainly will prove to make over the long term in terms of accessibility.
And I like that you said it's all over. It's not just medicine. It's what can virtually we do with nurses? What do we virtually do with our employees?
Right.
I don't want to drive an hour for a meeting. So it's everything that is it's gonna expand quickly, which I think is very exciting.
I was going to ask about the lingering health effects of those infected by COVID. Before I move there, though, I want to ask about the actual, this question was posed from the group, and that's, what are the organizations doing to support staff in dealing with the psychological effects of all the added stress, PTSD, chronic anxiety, things like that?
So I'll share, Mark, what we've been working on. It's probably not the longer term yet because we're still in this fight, but certainly during the pandemic, we've addressed the burnout, the stress, all sorts of ways internally, providing the resources. We have a wellness program within our system that we've extended out several times. We have our medical staff contributed funds to things like bringing in just ideas of everything from just sessions to talk about things, to massage chairs during the time, to recognitions, all that, as we're dealing with the pandemic. I think those are all shorter term. What it's taught us a lot is that now wellness and issues like burnout and stress have become a bigger topic in our conversations. Certainly at a hospital level, but within a system level, and that may expand it further. That has resulted in ideas on how to address that. So we're not there yet. We haven't developed it yet. As you all recall, burnout amongst clinicians was a big topic before the pandemic and slowly kind of increasing in scope. This has really catapulted it to really to the front of the conversation. So there's still long-term implications for this. There's still long-term ideas that needs to be implemented. I mean, we certainly have the counseling services and support services and all that available for those pockets where we've identified some significance, but I still think we haven't really seen the full impact of this, and that may be months to even years ahead. So I think it's a good thought as part of that package is what the future model of care is going to be. I believe that's going to be part and parcel of just looking at the clinical, the operational model, but there's also that, how do you care for our staff not only coming out of this, but in preparation for what seems to be just an accelerating demand for healthcare, across the country.
So going back to the disease itself, what have the lingering effects been on those infected by COVID?
So I'll share, and maybe Dr. Mohajer or Meyer has some concept that I see patients in a pulmonary clinic post-COVID, and I've seen them from all ages, from their 20s to their 60s. I've seen patients who've been hospitalized for a few days to a few weeks, and boy, every system is involved. Every system, from their musculoskeletal to their respiratory to their cardiac to their nervous system. Everything from psychological effects to just nutrition and inability to sleep, inability to concentrate, inability to return to work, in addition to the physical, their oxygenation issues or their cardiovascular issues. Remember, we've lost 500,000 people in this pandemic nationally, but there's many, many more that are out there post-COVID and recovering. That's a huge population that we're going to start seeing not only in pulmonary clinics, but in primary care clinics, maybe in it's readmissions to the hospitals and the EDs, all that. I don't know if we really even thought of that yet. Again, it's still early. We're still coming out of the fire here, but those effects are going to stay with us for a long time. We've had evidence in our critical care literature for many years, looking up to 5 years from those who have had ARDS, acute respiratory distress syndrome, severe illness, and multi-organ failure in the ICU, that they still have lingering effects 5 years later. Some of our COVID patients have been sicker longer, so we anticipate these effects may linger on for many, many years.
I totally agree. I think we have seen this problem as well. We have seen several employees who presented with COVID, and after they got better, took them a few weeks and some few months to get back to normal. We have created here at Bela a post-COVID clinic just to look specifically at this issue, with focusing initially on pulmonary, and more recently we're looking at the GI issues that are related to COVID, and do some more research on it, because I think this is an area that's growing, and we need to understand a little bit better about why it's happening and what we can do to prevent this issue or treat these symptoms.
Okay, we'll move on to another subject, workforce changes, and obviously everyone has been affected by this. We talked about telehealth and other virtual health approaches. So with remote workers, on-site versus off-site, and workers working roles across the county and state lines, are there advantages in just the use of space and in capital expenditures?
The answer is yes. I think we've learned how different jobs can do their jobs, not sitting on a campus, on an office. I think there's a lot surrounding in terms of how this will impact and what we will require them going forward. But the answer is there's no doubt that we've all learned to be not only effective, and I think that the conversation about how we have changed the work that we do. It isn't about driving across the city even, that we can do things on Zoom or on conference call and be more efficient. I think that that's really important. So there are certain jobs in all of our workforces, I think, that we've learned that can do things not sitting in very expensive hospital space. There are some that can do it very effectively remotely. And I think that's a process that we're all looking at very closely in terms of what will the long-term impact be. I think there have been examples already. I will use credentialing as one. For a long time, there's nothing new about that credentialing or coders don't have to necessarily be sitting on your hospital campus, or quite frankly, even being in your same city. And so there are jobs that we're talking about in relation to IT and other things like that, which are very competitive across the country, and having that discussion in terms of, are those particular jobs that, and what would be the requirements related to them if in fact they could live in other states and work in other states? What would we support? What wouldn't we support in terms of their travel, and what would those expectations be? So I absolutely would say that this has allowed us to relook at the work that's being done, where it's being done, and how to be more efficient.
Mark, it's also more than efficiency. I think to Deborah's point, it's definitely spot on. I mean, that's helped us become more effective and efficient in a lot of ways. You know, using another dimension to this, some of the meetings we've had, such as peer review, the medical executive committee that historically wouldn't even think about doing it remotely for the issues of confidentiality, privacy, that kind of stuff. We've done that virtually. We've done that now with all, and redesigned the way to do it so that those meetings and those conversations are still protected. They're still confidential, but they're still carried on in the capability that they should be as well. So again, it's amazing how something, when you're forced to do something, you learn. That's a lot of opportunity. Now that's also expanded the participation of people in meetings like that. When you had meetings with 3 or 4 docs, now you have a dozen, 15 more than that. On the flip side, of course, virtually is a little different than being in person for a variety of reasons we all understand. But I think it's like, you know, it's not a one size fits all, but just using this technology, I think we're going to be able to use it more. It may be refined a little bit. The working from home, that, as Deborah said, I've had a member working in the medical staff office who's been working from home for the last year, and she's doing fine. Others, case management, they tried it for a little bit, didn't work, came back. Some do it, you know, partially for this, partially for that. And I think it helps a lot with, again, cost, with the quality of life for some of our staff, reducing risks of being on the road and wasting time and all that. So there's a tremendous, tremendous potential, I think, that we can tap in using this capability as well. But it's going to take some time before we identify where it works best and where it doesn't work as well.
And I'm just going to jump in. I think participation is key. Look, this morning you had more than 100 on this phone call. And I'll share with you, as a healthcare executive that's been part of ACHE for almost 27 years, I haven't always lived in the Houston proper community. And getting down to a 7 a.m. meeting, it's not that I don't want to participate, but that takes some, it takes some planning, quite frankly. And right. So I think it is really important that it's not just about how we work within our organizations, but it's how we work across in all of these things. And so, you know, our medical staff participation in quarterly medical staff meetings has never been better than since we started doing it virtually. I probably won't go back. Our all town hall employee meetings for staff have never, I couldn't even get as many as we have logged on in a room as we have participation. So really you're compelled to basically say, do we go back on something like that? Or do we continue to do it in this format and then touch them personally in different ways? So those are just real examples of how this has changed and could be for the better, because communication and involvement and engagement is what we all want.
How about staffing in general? You know, we've had shifts in volume. Toni mentioned the second surge. Have there been, with the volume changes, have there been dramatic shifts in how you staff up? Is this a temporary thing, or is this a new model?
I would say some of it's temporary, some of it's permanent. Many of us did not just feel the medicine increase because of the COVID population. Deborah alluded to the stroke population has been, everybody in this city has been looking for stroke beds. Trauma has been higher than we've seen it. The violence in the city has been higher than they've seen it in probably 5 years. It has been, so there's some of that volume is going to take a while to balance back out. So I don't think we'll see a huge drop. What we're seeing in our ERs is a sign of that. Many people didn't get healthcare for a long time. So I think we're gonna pay for that. Staffing, we did a few things, and I'm speaking for us, but we read it across the country. When we shut down the electives, we had a lot of extra OR nurses. We had to figure out what to do with them so they weren't sitting at home. A lot of us went to team nursing because those were nurses that hadn't been used to being at the bedside for some time. So we had to get very creative in how we staffed those areas. We did some telemedicine with nursing. We put them behind cameras to help have extra eyes and ears when we were extended in areas that were not normally suited to be ICUs. The concern with staffing on our end has been the agency usage across the nation has increased 500-fold, 1,000-fold. So, and the amount of money paid for that, and it's not just nursing, it's respiratory, it's sitters, it's PCAs, that we've seen is not slowing down. It's not slowed down, and we expected it would start slowing down by now. So we've had to we've sent our nurses out and our staff out to do contract, and then we've paid for contract to come in. So it's been a very huge paradigm shift that we don't want to be in. None of us like being in the agency business as much as I think we are. We've had help from the state with the angel nurses, but that's going away. As COVID goes away, that's going away. And we still need to continue to find ways to have nurses in a very tough environment. Nurses who work in the medical center or the communities here, there's a lot of hospitals. There's a lot of competition. And I also think I'm going to brag for nursing in the Houston Metropolitan, and I mean in the community hospitals as well. We were ones that agencies wanted. Our nurses are prepared. Our respiratory therapists are prepared. They did well when they went to New York and they went to California. So we have a battle on our hands. And the nursing schools have been good. We're partnering with them to look at different ways. We did a designated education unit during the middle of the pandemic to get students in and instructors in and try to look at different ways to do it. So we're going to continue to look at this. Our central staffing is probably bigger than it's ever been in our system. I would think most places, if they could afford that, did that. And so we shared even across the system more than we ever have.
So Toni gave a good overview of the practice changes for the nursing community. How has this also impacted, respiratory therapy, physicians, and other ancillary services? So these are other areas that resiliency and response to needs of providers are all going to be impacted. Anybody comment on that?
Yeah, I think actually I'll just share. I think between this last surge, and I heard someone referred to it as we're going into a third surge. I feel like we've gone through three. So the upcoming after spring break might be our fourth. I don't know. But I will say that after December, January, and then you throw on top there the snow event that we had, I think if there were staff, and I just put that in a general, because I can tell you turnover, when I look at turnover in our organization, it's not in one specific area. So when I look at that, I think if someone was thinking about and evaluating their personal and professional stress, they probably weren't going to leave last year because of all the unknowns and just job, I will say, just that job security. That was a conversation that was happening across the board. But I think that if they were remotely thinking about it, that change is happening. And if they're thinking that I'm out for whatever reason is, because there's personal stress and professional stress, they're out. And I think that is posing an incredible stress for all of us, compelled to think about not only how to do the work differently. I think Dr. Almoosa spoke to that beautifully in terms of there's great lessons learned, basically because we had to, and I think those will continue. But I will also say in terms of how we staff, how we get creative in staffing, how we basically build that pipeline in and continue to do that is going to be essential. So I think it's all those things. I don't think there's a magic bullet here. I think we are going to be faced, and I think it's happening now. I think this is going to be a really telling and challenging year for all of us, because I think those that, again, want to make a change are going to do it. We're already seeing it. So it's going to pose an even greater stress on our systems as to how to do the work. That's at least where we are.
And yeah, they've made different choices, right? Some are like, nah, I don't want to do this. This isn't what I signed up for. And so.
Same thing, Mark, from the physician perspective. I want to underscore what the point that Deborah made is that we're all thinking, including myself, let's say in the next couple of months where everything's progressing well in terms of COVID, the numbers are coming down, people are vaccinated, it's all over, we're going back to normal with a few different changes. I don't think so. I think the impact of all that's happened, we're going to start paying for it in many different ways over the next year or two, or maybe longer, from all the different topics we talked about. This from the staffing part, you know, physicians, same thing. We've had docs who've stretched so much the volume of patients that they had to see, the acuity they had to deal with, in addition to the stress of exposing themselves to the risk of getting COVID themselves and their families, and dealing with all that. You know, sure, it's helped us define what's an adequate number or not adequate number, and, you know, can we staff differently, have other specialties come in, you know, manage inpatients when historically we haven't done that, getting nurse practitioners as physician assistants where historically they weren't. I mean, all those things are the immediate, you know, obvious things, but the long-term impact is yet to be seen. So that's something that I think we should all prepare for as we recover from this.
Yeah, I think the long-term, in some areas, the long-term patients with the death and dying is not something the nurses or the physician, anybody in those areas, even the chaplains, has seen. And I'm with you, Dr. Almoosa and Deborah. I think long-term, I'm more worried about that, honestly.
I concur, but I would also say, I don't think any one of us feel good going home at night or waking up in the morning. I think we all have an unbelievable sense of concern about essentially how the ERs are literally are overburdened, and we're all probably holding half a unit to not a whole unit consistently, day in, day out. And I think that just on the workforce itself is incredibly stressful.
Question from the group, again, about another area of stress. Are there any organizations looking at student loan help for critical employees?
We do student loan help. I think many of the organizations actually do. Yeah,
we do. But, yeah, I think most of the medical center hospitals of some sort have an educational reimbursement component to one of the benefits.
Okay, so we had this winter storm. We've all experienced. Some of us got the worst end of it, and some of us managed to get through it okay. What about the medical community? Your response to circumstances that are unprecedented, both from power and water supplies, what was that experience like?
I have to tell you, I think our staff was like, yay, we know how to do this. It's like a hurricane. I mean, they all showed up. We were trying to send them home. We're like, y'all gotta go. We have too many, go home. So in all fairness, for them, they were more comfortable in that environment than they were. I don't know how everybody else felt, but we definitely went through that much smoother than, because they're used to the hurricanes.
I'd say we did it. Unfortunately, the same challenges that all of us, in fact, there was a great editorial that was in Houston Chronicle yesterday that I believe Dr. Klopman wrote, the same challenges that have come up every time about outpatient dialysis and how our communities respond. It's consistent. We don't have, I think, the right approach yet. So I think it has propelled us even more to say, we're not going to do this again. What's going to be that next step approach and plan before we go? So it highlighted, once again, some of the things that we haven't necessarily figured out for the community. And maybe that's because we have all, as Toni says, the other stuff we've got covered.
Yeah, we're used to disaster relief here in this community. And I know the pandemic just added to that. We learned some other ways of dealing with it on a large scale. Any other lessons that came out of this that allow you to make plans for the next one?
Mark, I'll sorry, Toni, go ahead.
No, go ahead.
I was just going to say, just looking at it from what Sean talked about earlier in that black spot in the white page, the example here is, I mean, during that week, that horrendous week, on top of everything, I can speak for my two hospitals, with just the overflow into the ED and the hospital, that is just unprecedented. We managed that so well. I haven't heard of a single case yet of, for example, a significant safety event because we missed something or because we just didn't do something for it. It just attests to the incredible capability of our healthcare workforce to manage disasters and manage something like that. And I know it's not just our organization or our hospitals, but again, a reminder to the group that there is so many good things that are going on besides the problems that we tend to focus on. And that's, again, just a tribute to our healthcare workforce and something we take a lot of pride in.
Our hardest time, and I don't know, Deborah and Dr. Almoosa, if you felt it, was when we were beginning to come back to this next surge. It was the impending doom that everybody felt. It was, right. That was the hardest month for me. We had more people leave, and I felt the same way. I'm like, I just really don't want to do this again. Please don't make me do it. And so I think once we really had to work really hard getting in front of everybody during that time. And then once you were in it, they're all working again, right? But when we saw it coming and the numbers every day were just going up so high, managing that, even my own emotions with that were tough.
So with all this added stress, is there another question from the group? What kind of advocacy is being done right now for the health systems in general, and make sure their voices are heard and finding ways to help? Or are you guys on an island?
No, I mean, I think it's fair to say Texas Hospital Association and other state governing bodies. I mean, I'll say CETC has worked really hard to bring all of us together and to communicate. I will say the governor has had, with all CEOs and other healthcare leaders, he has had some state calls. Again, THA, I think, has worked really hard to keep all healthcare leaders apprised of what's going on. And I think if you ever hop on a call, you have appreciation for kind of what's happening around the state. It's, it's not all about what's happening just here. And so I think that there are certainly, governing bodies. I will say, with all of that said, when the governor came out and lifted the mask mandate, I thought, well, our governing bodies probably didn't do enough with the Texas Hospital Association, Texas Medical Association, if we really felt so strongly, or maybe our voices really don't carry the weight that we think it should, in fairness.
I'm going to throw out a couple of quick questions and see if we can circle back on. I know some of where people are anxious to have a few more vaccine questions answered, but the term new normal, we visited that before. What is the impact of all this on visitation policies, and what is the lingering impact on the communities served?
Yeah, go ahead, Dr.
Go ahead, Toni.
Our visitor policies, and I think we said it before, and Deborah was right. I like that we have been able to work with other systems and be fairly consistent. And when we made changes to visitor policy, why we made changes, the communication got out via the newspaper. It was on the radio, and so I felt like it was as well done as it could possibly be. So before people came into the environment, they knew what to expect. Of course, we didn't hit everybody. The other thing is, I do think long-term, we may revisit some of our prior visitation policies. Those of us that had very open visitation policies sometimes maybe had some safety issues depending on the scenarios in your hospital. So I do think we will rebalance at some point and actually look at what works and what doesn't work. It will change what we've done.
I agree. I think it's not going to be the same as it was before. Now it's being rolled out very slowly. We're slowly relaxing it, and there's some pros and cons to that. I mean, at the beginning of the pandemic, and you want to reduce visitations for the purposes of protection of the public, protection of our staff, of all that stuff. But during the pandemic as well, when you had significantly sick patients where you needed family or people to come in and help make decisions, but not only that, but the moral distress that not only staff felt, but family felt of patients who were dying, that was a significant other extreme to that. So there's got to be something in the middle. Interestingly, over the last couple of months, I've heard a lot from physicians that wanted us to again bring in visitors and bring in family, because it's good for the patient's well-being as well. And that's something I didn't hear a lot from before. It's a lot easier sometimes to manage patients without all the visitors sitting in the room. So this is not a simple, let's just turn it back on the way it was before. I think as Toni alluded to, there's going to be some fine tuning of how and where and why we do this, but we're extremely cautious now about how we slowly open that. So it is there, we support it. It's good for patients' well-being. It's good for staff as well, but we got to balance that as well with the public health measures.
Okay, I'm going to circle back to a few other questions. What does it mean for a health system to be designated as a state vaccine hub, and what are the expectations from a state?
Essentially, when they, as a designated vaccine hub, you have a responsibility is basically in vaccinating the county. So when someone says to me, well, do you only vaccinate your patients? Meaning they must be a registered patient with you. The answer is no, you have to vaccinate essentially those. And when they say we are under, in terms of the allocation, they're trying to actually get the vaccine out to those in certain zip codes and counties. And so that's really one responsibility. Again, working with your federally qualified health centers, working with those who are underserved or those who are most vulnerable populations. We've all gone through a different way about going that. You've heard about particularly working with seniors who might not have been able to access technology. How would you go out and go do that? So it is about going above and beyond the responsibility of, let's say, your medical staff, your hospital staff, and quote unquote, your patients.
This question probably needs a little more context around it, but I think it was a question that was answered earlier. And as somebody asked, do I understand that the governor decides how to disseminate vaccine among counties?
Well, it's through the office, right? So the allocation goes to the state. So it's through his office, and they look at the doses that have been administered by counties, regardless of how it gets administered or who's administering it.
Everybody turns in, I think, what they use in a week. The next allocations are made. And sometimes there's adjustments because the state may get more vaccine.
Right.
Are there any documented cases of people who have received the vaccine testing positive for COVID-19 post-vaccination?
Yeah, there are many cases that we have seen. I mean, just want to remind people that the vaccine only is 100% effective against severe disease. So it's 95% effective against mild disease. So there are 5% of people who get vaccines can still get COVID. And we want to be sure that just because someone gets the vaccine, that they shouldn't really drop their infection control measures like social distancing or face cover, except with the exception that the CDC allowed. So we need still to practice some measures of infection control because of the vaccine does drop transmission. And actually data published, today by Pfizer, and there's similar data by Moderna that the vaccine decreases transmission but none of these vaccines has 100% reduction. So I see some articles on the news and say, oh, someone got COVID after they got the vaccine. And it's a little bit misleading, because if we never said that the vaccine is 100% effective in preventing mild disease, it's very highly effective. It's much better than the flu vaccine or any other vaccine we have, but it is not 100%. Now, I want to mention that the CDC did publish recently guidelines related to if someone is vaccinated, they can go and visit their family members, like a grandfather can see their children if the grandfather is vaccinated, and they don't have to wear a face mask. But that does not mean that people who are vaccinated can like have a group of 30 people and have dinner together. So still, we have to practice our judgment and follow CDC recommendations. And the CDC guidelines allow some leeway if you're vaccinated, but it does not mean we just kind of forget about infection control measures since we're vaccinated. It's not 100% effective.
Is there much concern over waste due to the specific storage and shelf life requirements for the vaccine? Is there any tracking being done on this and accountability for vaccine distribution partner rates considered higher than expected?
There's a lot of tracking. They track every dose that's given by lot number. There's a lot of tracking that goes to the state. Every wasted dose is tracked. I know, and I can't speak for everybody else. It is a hustle. When you open one up and you have 6 doses, I mean, you have 5 to 6 doses, you have 6 hours to give it. If people aren't showing up on appointments, there are phone calls being made immediately. Pharmacy has been amazing helping nursing, and there are calls made every single day to make sure we're backfilling to make sure that we can take care of the dosage. And let's say we have one person show up, we won't open a new dose unless we can ensure that we can give all of those dosages. That's what makes scheduling so difficult.
I'd agree 100%. And I think this is also where, looking at from the state, all of us feel a sense of responsibility to do this, do it really, really well, because that could hinder your ability to get more vaccine. And so if they don't see it moving, they don't see it going in arms, that's where the allocation or reallocation occurs.
How long, have they tracked how long the immunity actually lasts in various vaccines?
So that is a really good question. The data is still not there. I mean, the studies have just been recently published. So we don't know exactly how long it lasts. We know it's probably at least for 3 months, and the CDC guidelines related to quarantine recommended that people who are vaccinated, they don't need to quarantine after exposure, with the exception of travel, as long as they're vaccinated within 3 months. And the CDC give the ration behind that we don't know if the data will persist beyond 3 months. We believe that it's probably would be protected beyond 3 months, but I think we need to get more data to be sure. It's going to be 3 months, 6 months, or a year. That the jury is out on this question.
Thanks. Let me move back to Noel. We got to wrap this up as it's 9:26. This has been a phenomenal discussion. I think we could probably talk about this all day with a lot of other tangential discussions. But let me hand this to Noel to wrap up.
Yeah, Mark, thank you. I want to thank Mark for obviously leading the discussion and moderating the panel. And I hope I get this right, Dr. Mohajer, is that correct?
Yes, that's correct.
Thank you, Deborah. Thank you, Dr. Almoosa, and thank you, Toni, for just having just a great discussion. Even things that I live this each and every day, as a CEO over 2 hospitals, I learned quite a bit this morning from the group, and I appreciate everything that you all put into this, because I know being a panel member, because I've done this a couple of times, it takes a lot of effort and obviously being prepared for it. And y'all did just a phenomenal job with this morning's discussion. And I want to ask all our those who are participating right now to just give you all a big round of applause. So I'll start off by just giving y'all a big hand. So congratulations and thank you all for being here with us this morning. So I'll just go ahead and close up this morning's session and this breakfast event. And but we do still have several events that we're planning going forward. So we've got a guided virtual sake tasting event this next Thursday, March 18th from 6 to 7:30 p.m. You can still sign up for that. It will be recorded, so you can still take part, even though you cannot make the event live. So sign up now. There are still some openings, so take part in that. And plenty of sakes included to share with your family and friends. All proceeds will go to our scholarship fund. So again, I encourage you all to participate. Our Board of Governors exam review course will begin on Thursday, April 1st, and will run for 10 weeks. We had a lot of success with the one we did last year. We had members from not only within our chapter, but within the state, and even across the country. And we actually had a couple members from overseas that joined our session. So again, that's 2 hours of instruction per session that'll run 10 weeks. All sessions will be taped and provided for further review, or if the session cannot be attended live. Take the course and further your work towards achieving your fellow status with ACHE, the gold standard of healthcare executives. And I always tell everybody, you know, you're a member, why not take that next jump and become a certified healthcare executive? Finally, we'll have a morning to volunteer and participate in the community service at the Houston Food Bank on Saturday, March 27th from 8:45 to 10 p.m. I encourage you to join. Of all these remaining events, for information and registration, it's available on the chapter website. If you have any questions, you can also reach out to Mark. But again, this is really about giving back to the community that's given so much, and also a community that has just endured and still going through you know, a lot of challenges, especially for those that have been struggling most, that have been impacted by not only the virus, but as well as our weather events, and then of course, the impact to the economy and loss of jobs. So again, highly encourage you to get out and participate. It's obviously a part of what we are as far as ACHE members, in that, you know, not only do we give back in our profession, but we also need to give back to our community. So if you have some time, please take that opportunity to volunteer. I hope you've enjoyed this informative panel today, and we're looking forward to the next one. Mark's got several things lined up for our chapter, and he's working on those. And again, go to our website and you can get all that information. And we'll see you all at the next breakfast event or panel discussion. And again, doing virtually, as Deborah said, this has really expanded our opportunities with our chapter. I know it's something that as a board, a chapter board, we've been talking about, and we know that this is going to be part of our structure going forward, because with our area being so large, and obviously the challenges of traveling, we know that we need to be able to continue to do these types of events virtually to support our members. So again, thank you all for joining us this morning. Be safe and stay healthy.
Thank you all, panelists and Mark.
Appreciate it. Thanks for the opportunity.
Debbie, I hope this is the last quarter. We don't go into the 6th quarter of 2020.
I hope so too. I'm right there with you. Y'all have a great day. Bye-bye.
Take care, everybody.
Bye.
Thank you very much, Trevor.
Thanks, Mark.
Thank you. I went really well. I mean, I really think we probably could talk about some of these things for hours.
Oh yeah, I mean, this could go on for an all-day event.
Yeah.
And so much to learn from it. I think we're good. You need anything else from me at this point?